came to light because I think this meeting or this topic came to light in part because of COVID. We always have difficult conversations with our patients, but we had many more and many in very short periods of time. So I think that this came to light and was requested by some of our providers in our service. And there's no better group of physicians who are able to kind of counsel us and give us some tips on starting these conversations. So we asked Dr. Hurst to come, and so he's graciously donating some of his time to give us some tips and kind of goals of care and kind of these end of life talks. So you're one of our own palliative care doctors. With that, I'll let you take it away.
All right, thanks, Ashley. I appreciate you having me, and glad to get a chance to talk to some of you guys. That's, from my perspective, really no better way to disseminate some of what we like everybody to know about how we approach a goals of care conversation. And so I'm hopeful that we can get kind of some practical advice, and y'all are welcome to ask questions or tell me I'm wrong about things, or tell me that your experience has been different than what mine has, and we'll welcome any of that. But am I able to share my screen here? Let's see.
I hope so.
Yeah. Is that seemingly working? Yes. Okay. So my primary focus is really going to be about communication, but there are just a few pieces of background. I think my first 7 or 8 slides that I'll go through kind of quickly, because I think it's important for everybody to start from the same place as far as what I generally do as a palliator, and maybe also some of the specifics of how we here at UAB take care of patients who have palliative needs in some way. But my real focus will be on a framework for difficult conversations, specifically surrounding goals of care, and then also on some pearls that I have found to be useful even through my career thus far. So I'll start with just this case study, just to as a way to give an example of or multiple examples of how we try and intervene on folks. So this was a lady I saw probably 3 or 4 months ago, but a 79-year-old who had hypertension and coronary artery disease, AFib on Coumadin. She had some cognitive impairment and was living in assisted living. Came in by EMS after being found down with a hemorrhagic stroke and a supratherapeutic INR. From her Coumadin. GCS was 5. She was intubated, got reverse anticoagulation, and had an evacuation of the bleed. Initially was ventilated and started receiving feeds by Daboff. Unfortunately, within several days, or really a week, she was not having neurologic recovery or able to participate with therapy. So close to a couple of weeks into this hospital stay, she got trached, and PEG happened at the same time. She was transferred to the floor, stable enough to do so. Slowly, with a little bit of neurologic recovery and at least able to open eyes and recognize that people were present. She ended up getting expected complication of sepsis and back to the ICU for pressors about 2.5 weeks in. Also had AFib with RVR around that time. Ultimately, several days later, ended up with AKI related to hypotension from her sepsis, and worsened to the point that CRT was required, was delirious, as many people are in the ICU, and then acutely had a change in neurologic status with a new ischemic stroke found on CT on day 28. So we were consulted a couple days later for help with goals of care specifically. So we'll come back to this, but just kind of a very usual consult for us from a medicine service or medical ICU service that we get every day. So very basically, palliative care is just specialized medical care for people with serious illness. And we want to help with symptoms and stress of that serious illness. Is for both patients and families. You do not have to be dying. You just have to have some kind of serious illness of some kind. And with a goal of providing an extra layer of support. As I said, it can be appropriate at any age or stage in serious illness and can go alongside curative treatment. One of the easiest ways that I have of showing this is at Children's. We follow burn patients who are fully expected to get better, but have significant pain and PTSD and anxiety needs. that we are coexisting alongside a curative treatment regimen along with the burn team there. So most simply, palliate means to make less severe or unpleasant without removing a cause. So I don't fix much, but I try and make those things that we can't fix better. And that's pretty analogous to probably most of my life. And in fact, if you look up palliate, there's a website called wordsinasentence.com where they use words. And this speaks of palliating the symptoms of a hangover that's expected to happen the next day. So we don't fix the cause, but we can make things better. But don't call me for a hangover because I'm not into that. So anyway, most broadly, I define this as relief of suffering of any kind, and also expert communication to help guide medical decision making. And this is just a pictorial representation of that suffering comes in many forms. Yes, physical is the primary thing that we think of, but there's also social and emotional, psychosocial that we see so often, spiritual suffering, there's financial and other, so lots of domains in which people can suffer in some way. And while I can't fix all of those, those are at least things that I try and understand and address, because it really affects how people look at their medical situation and ability to improve, or what things look like as they're dying. So we do have this interdisciplinary approach, that these are a few of our interdisciplinary team members, the provider like myself and our other attendings, and our nurse practitioner or PAs. There's pet therapy, nursing, there's social work, there's massage therapy, there's counseling, there's pastoral care, and we all try to work together. This is most visible on our palliative and comfort care unit, where we're consistently working together with overlap everywhere. And this picture isn't exactly right. Like, actually, I work fine with pastoral care, even though we don't really overlap there. Like, they love me, but I just didn't do the diagram very well. So lastly, from when we think about palliative care through illness, it's kind of evolved over time. So there's this initial idea that there's a period of attempts at curing, and then when that fails, or when that's clearly about to fail, we shift to this idea of palliation. Then someone dies, and then there's bereavement, for which we follow up afterwards. So that is how this started. And then we were super proud of ourselves for being like, actually, these should be parallel, that there should be some degree of palliation that starts out minimal towards the beginning of a chronic disease process, whether that's cancer or COPD or even something like diabetes, that increases as the ability to cure decreases, and then death and bereavement. And in fact, the most updated way of looking at this is really that this integrative rather than parallel approach, that palliative care should be involved not only from the beginning of the diagnosis of serious illness, but that part of that is bereavement that starts on the day of diagnosis. The bereavement for loss of the normal, and that's continual throughout the process, through the pre-death period, through death, and then post-mortem. And so this is really how we like to think about things in an ideal situation. Now, don't get me wrong, you guys see so many people, so there's zero chance that I can see all of the people with serious illness. So please don't consult me for that. But that's part of what I'm trying to get at here, is to help you do at least a little bit of what we do and what I do as a small part of this team from a proprietor standpoint, so that you don't always have to rely on me or one of my colleagues, but I'm the best of us. But don't tell anybody I said that. Okay. So this slide is added a little bit at the request of our administration, which I don't see if Jennifer Hicks is on here or not. She is. Well, that's wonderful. But the reason is that I want you to understand how I'm approaching taking care of a patient. I tend to think about, okay, is this a palliative care patient? Is this a maybe hospice patient or a definite hospice patient? Or most notably, this third column for general inpatient, or what we call GIP, hospice. So really, hospice has four pieces to its care, and that is routine home care, where nurses and other interdisciplinary team members may come once a day or once a week or 3 times a week or whatever. And more intensive than that, there is continuous home care, where there's at least 8 hours that a nurse spends, or a nurse or another interdisciplinary team member spends in a home over the course of a 24-hour period, for uncontrolled symptoms or some other acute need. And when or if that continuous care fails, or sometimes we skip the continuous care approach because it's rare that things are bad enough that they can't be controlled somewhat with routine care, but could be controlled with continuous care, so that we look to a GIP or general inpatient type of care. And so that's a different thing than our palliative and comfort care unit. Our palliative care unit is just that. It really has nothing to do with hospice. It just means that people have a palliative need. Are many of those people dying? Yes, about 70% of the people who come to the palliative care unit die there. But when you leave, you don't have to go home with hospice. That's still a process that we can figure out. The benefit of this GIP is several things. One, that it and I should mention the fourth piece. So there's continuous care, there's routine home care, there's GIP, and then there's respite care, which is a separate category altogether. That, a family wants to go to Breckenridge and they don't want to take grandma because she's going to slow them down in her wheelchair. So they get 5 days of respite through hospice as part of that benefit. But for people who are symptomatic and can't be controlled at home, those people can have relief of symptoms in a general inpatient setting. And so now our unit is essentially two separate units, one that's our normal palliative and comfort care unit, but a couple of beds that are available for GIP patients, which means they can stay admitted on hospice or they can be admitted to hospice. So if they come into the hospital from hospice for uncontrolled symptoms, they can potentially be admitted to our unit on this GIP status, and hospice doesn't have to sign off, so they can continue to follow them. Or if they are maybe approaching end of life or appropriate for hospice going home, but aren't quite ready to do so and need a transition through more intensive symptom management and more clear disposition and that kind of thing, then they could go potentially from an acute inpatient to a GIP inpatient admitted to hospice, and then transition to home with hospice. And lastly, this doesn't count against our mortality numbers. So because they're not really admitted to UAB, they're admitted as a GIP, we can give people good intensive care at end of life or otherwise. And it doesn't have to be problematic for the hospital in any way. So Jennifer, I'm sure you're going to be really unhappy with how I said all of that, but that's my plug for GIP. Just call one of us and we'll help you to figure out if you think you may have a patient who qualifies like that. All right, so that's done with the boring part, but actually none of this is boring. It's all amazing, but that's probably just because I love what I do. I have one slide about advanced care planning, just so we know the framework in which we're talking about. So when we're talking about goals of care specifically and communication around goals of care, that can happen at any point along an illness trajectory, but we really start to think about it as people are worsening in some way, whether they have multiple rehospitalizations or there's some new indicator that disease is worse, you're the next worst level of COPD or heart failure. So then we're really thinking about this umbrella of advanced care planning, which doesn't have to wait until then, but for most people, it ends up waiting until then. And under that umbrella, there's organ donation, which I won't go into, but then there's this idea of advanced directives, which are both a living will that Alabama has a form for, and also a power of attorney that can be part of that living will, somebody to make your decisions when or if you're unable to. And then there's this other side that's specifically medical orders. And the important thing is that advanced directives kind of maps to patient goals. It's mostly in patient language about keeping me alive if there's no hope of recovery, whereas medical orders are things like a DNAR order or a MOST or a PULST, which are medical orders for or physician orders for life-sustaining treatment or medical orders for scope of treatment, depending on the state that you're in. Here in Alabama, we've mostly adopted this PULST idea, but it's not fully official yet. You can look up all the different states, it doesn't matter. So really where we're focusing here though is this last part of durable power of attorney and living will, but really for our purposes, especially here in the hospital, which is the only place that I work, the medical orders and DNAR, and how do we approach getting to that point? Okay, so questions so far, concerns about that? Now we're going to get to the stuff that I hope is really most helpful. And I realized as I'm making this presentation that this is such an old, I went to medical school starting in 2007, and this is really an old way of like, you do some slides, you talk about them, and then you throw up this funny comic, and somehow that's supposed to keep people engaged, but it super doesn't work. Like maybe you blow air out of your nose like a little bit faster than normal, and that's it, but you don't ever actually laugh. Here's the problem though. I was like, we need to update this idea of comics with like a TikTok or a meme of some kind. But if you search palliative care memes, you know what you get? You get this. So this is from the 1987 classic Princess Bride, which if you haven't watched it, you definitely should. But also we can learn a lot from Inigo Montoya, as we will see here as we start the communication section. So communication, I'm just going to tell you everything about that I know about communication, and we're going to mostly do that through lots of role play. Like everybody is going to be involved and role play back and forth. I just saw like 6 people drop off the call. No, I'm just kidding. We're not going to do any of that garbage, but it is a valid way of learning this, not one that I'm going to make you learn. So when it comes to communication, what's important? Well, there's actually, speaking of Princess Bride, I'm sorry, I'm not that obsessed with this movie. It just came up twice in my research here. So there's actually a way of communicating, mostly in the business community, that this man from the movie, a secondary character, a relatively secondary character, illustrates pretty clearly. And that is a polite greeting. Hello, your name. My name is Inigo Montoya. How are you, like, why do you matter to this person? Well, you killed my father. And managing expectations. What's next? Well, prepare to die. So that's a very, very simplified version of how I talk to people, except I generally don't just say prepare to die. There's more that goes into it than that. So we all know, or maybe you do, maybe you don't, this is a very granular way of looking at a specific conversation, right? Spikes. Make sure that you're in the right place, the right people are involved. Get the people's understanding, get the patient, the family's understanding, ask them if you can share information, then share that knowledge, tend to emotion, which you're doing throughout, unless you're a serial killer, and then make a summary or strategy at the end. And so that's not really what we're focusing on, because we all generally know how to have a conversation that moves along and getting towards a goal with a family. This is bigger picture. This is a zoomed out view of how do we approach this specific granular mnemonic for having a conversation with a patient or family about serious medical illness. So what is our framework? I've been talking for 18 minutes and I haven't even told you about what the framework is, but here it is. And we're going to keep coming back to it. It's super complex, right? So we're going to talk about each part of this individually and then all of the connections that happen in between. And if you can know and remember this and map pieces of this to some of the things that I'm going to say, then that's really all that you need to know to have the magical kind of goals of care conversations that we do. Yes, there are lots of specific words and phrases to use and to not use, and we're going to talk about some of those. But this is what really, really matters when it comes to understanding and truly understanding someone's needs and goals and desires, and then helping to recommend these are the things we should be doing, these are the things we should not be doing. So within this framework, here's what's very important. It's this idea of paternalism versus autonomy. And the old school method is like, really old doctors who you imagine they're talking with their patients and the patients are like, oh, whatever you say, doc, like I'll just do what you say and that's fine. I trust you. And now kind of this new idea or newer idea of patient autonomy of like, well, I'm not going to tell you what to do. You can make that decision for yourself because I'm not going to put that on you. That's up to you to decide. I'm just going to give you information and expect you to assimilate that and come up with a reasonable decision. And there's 3 points to take away from that. One is that it is our role as a provider to make a recommendation. We don't just present information. That's what a student does. Maybe like I can read you what the labs are, what the imaging showed, but stopping there and saying, well, your kidneys are getting worse and worse. What do you want to do? Like, generally nobody talks about it quite that simplistically, but in essence, that's what we're saying a lot of times when we present information and say, what do you want to do? And in fact, there's a lot more steps that need to come in between there. So I'm very much a car guy, all things cars. And so all of my real life analogies, many of them have to do with cars. So who knows what this car part is? Nobody does, because why would you? So the example I like to use here is that your car gets a check engine light because presumably your car was made after 1996 when OBD2 was mandated by the government. And you go and get it read at your mechanic, and he or she says, well, your idle air control valve is bad. And that's what this piece is here. And it's not anything you should ever have to care about as long as your car is working well. But your idle air control valve is bad. What do you want to do? And then you just stare at them dumbfounded, like, what, are you, an idiot? I have no idea what this even does. How can I tell you what to do? Does it mean my gas mileage is going to be poor? Does it mean my car is going to cut off at stoplights? I'm going to have to buy a new car. This is a small problem. This is a big problem. I was about to replace this car anyway. There are lots of pieces that go into what do I do next, or where do I go from here? And so I have to rely on the mechanic to tell me, oh, well, given all of the things that you're telling me, here's what you want to do with this problem. And so it is not nearly so simplistic as with a human as it is with an inanimate machine like a car, but it's the same concept. We are much more expert than almost any of the patients and families that we're seeing. And so we have to provide recommendations. And we say, well, we can't tell them what to do. Of course not. We have to understand what's a reasonable decision based on where this person is medically and based on what things are important to them. So here's how we get there. That's a boring quote. Let's skip that. Okay. So we have to start in this communication framework with some amount of diagnosis. And you're going to hear me use the word uncertain, like probably a lot more than we're comfortable with. But that's okay. It doesn't keep us from being able to move through this framework. We like to start with a diagnosis, like, oh, you've had a biopsy for this lesion and it looks like you have lung cancer. And in fact, it's all over your liver and everywhere else. So you have widely metastatic lung cancer. Or, you have cirrhosis and we think it's from alcoholism, or, whatever the diagnosis is. But either way, that diagnosis is not always completely certain. And again, I'll use a pediatric example. There are all these kids with lots of genetic disorders that we're doing genomes on, and they're not, definitively, they don't have something, however, that we can name. However, you can see in a lot of cases, even without a diagnosis, how somebody is generally doing. And by that, I mean, what's your baseline? What are you doing at home by yourself? What has your decline or change over time been? Decline or improvement over time? Because what's more important is prognosis. So we generally will use diagnosis to get to prognosis. And if you have a new diagnosis of diabetes, well, the prognosis is probably pretty good. But if you have multi-system organ failure, even without a known cause of that, a known singular cause of that, then we can say, I don't exactly know why, but your prognosis looks really terrible. So that's the most important thing that we can get to there, except, sometimes that's uncertain too. So how do we give certainty to something that by definition is uncertain? No one knows. And you'll hear patients say all the time, like, you can't tell me how long I'm going to live, or you don't know, or only God knows, or all kinds of things. So we have to talk about ranges. And this is based on not so much data. I don't use, like, well, you have this type of cancer, you're getting this kind of chemotherapy, so this is your cure rate. A lot of times I'm not seeing people that early in a disease process. And I'm more looking at, gosh, you're telling me that you were driving and you were teaching school 4 months ago, and now you've lost 40 pounds, you're mostly bedbound, you're weak, you're now in the hospital because you've had an infection. And in fact, this is the third time you've been in the hospital. You're having to get more help at home. So I can already, this person, I don't care what they have, that I'm thinking we're probably talking about months to maybe year here, or somebody who's acutely ill and needing pressors and maybe temporary CRRT, or maybe CRRT that we can't get them off. Then I'm thinking more, this could be a week situation, or you're imminently dying. I'm thinking this could be a days or hours situation. So I don't, and the problem is that someone will ask a specialist, well, how long do I have? And the specialist will say, oh, well, I don't know. There's no way I could know. And that's true. But the next question to ask, and I tell patients this, to ask their specialist this is, okay, I know you don't know. I'm not going to hold you accountable, but what would you expect if you had to guess about what you would anticipate to happen? Just give me a guess, because here's the thing. Without a prognosis, you can't do a good job of formulating goals, right? So I assume right now that I have at least a decade to live. That's probably true, although I do a lot of dangerous things in my life. So given that, though, my goals with that potentially at least decade, okay, probably more than that. I'm only 37. It's not like I'm not about to die, I don't think. But given that, my goals are very different than if you told me, well, you have 2 months to live. I'm focusing on totally different things. And so that's different whether it's months or years or weeks or months or even days or weeks. And so you have to give somebody some ability to make decisions. And it may be that when you're having a conversation about difficult illness, you say, man, it's far enough out that I would be really surprised if you died in the next year. And maybe I don't say that, but I think, I think you would at least have a year to live and potentially more, or at a new chronic diagnosis that is ultimately going to be fatal, but maybe not for 5 or 6 years or a decade, then we can say we feel pretty certain that this is a long way off, but how far we don't know. We'll know better as we get closer. But you have to give the context for somebody to be able to create goals in light of a prognosis. So we're almost to actually making those goals, but this requires understanding what is my diagnosis, or an approximation of my diagnosis, then what is maybe what I think a prognosis is. And then the question is, so in light of these things that I'm telling you, in light of your diagnosis and prognosis, therefore prognosis, what are the things that are important to you? And you can't fully answer that question until you understand where this person is coming from. So somebody who's grown up with a very different social situation or family or financial situation, their values, their beliefs, even their understanding of their illness is going to be different because they don't have the medical training that we do, or there are lots of reasons for this to be different. So this is where there's the most variability. There may be people who say, oh, well, I believe that I'm immortal because, this omniscient creature has told me that, or something. And so you have to start somewhere. And here's where I really like to start. So that's based on culture and what is a person's personal beliefs. And these sometimes become apparent as you start thinking together about what are the things that are important to you. But practical, that's a good, easy place to focus, to say, look, the things that you're capable or incapable of doing, which of those are most important to you? Or what would you say is beyond a quality of life that is acceptable to you? And it's weird to talk about, but it's more than okay to say, there's a certain quality of life that is unacceptable. And I've always said, I think I get less certain as I get older, but if there's a point where I can't race and drive anymore, then I'm not sure that I want to live in that world. So that's a very low threshold for saying, look, pull all the plugs, even if there's no plugs to pull. But it very much it maps to something that's very objective. Now, social, there's lots of other things. How does my family feel about my life and my legacy and my age? There are some families who get very angry when you start with, gosh, your mom's 102. Do you think it's unreasonable to think she might not live another 35 years? Which I've literally had someone tell me, a 102-year-old is going to live another 30 years. So you have to understand where they're starting from, where they're coming from, and then spiritual, especially here in the South, we have to do our best to not make this weird. And it's not. It's just a part of the assessment that's important to understand, that where do you get support or comfort from? And many times people will just say family, but are there any community groups or other groups that help to give you that comfort in the midst of scary situations medically? Because I'm not going to get very far if I refuse to even acknowledge that a person's spiritual beliefs very much informs the decisions that they make as they relate to goals of care. Okay, I'm going to take a breath for a second. Sorry, I get super excited about this stuff because I'm really into it, in case you can't tell. But so we're kind of halfway through this thing, right? In that we've talked about diagnosis, prognosis, understanding and values and beliefs that you can spend lots and lots of time on as much as you want. There's all these other pieces of this, right, that are part of the American Society of Clinical Oncology is where this is from. But even parts that we haven't addressed, but that's part of what our interdisciplinary team is trying to do with our, our medical team here at number 1 and number 2, our counseling team with number 3, our social work, counseling, and chaplains with number 8 here. Oh, I'm going out of order. I'm sorry, this is clockwise. We've talked about 4 and 5 and 6 and 7 and 8. Okay, that's all of them. But like, these are the kinds of things that we like to surround patients and also families with total understanding. And there are times where I find out things that nobody else has, or other people find out things that I haven't. Let's be real, there's way more of the second of those. But it is really, it's important to have a good understanding of who is this person, not just what is this disease. And that doesn't always have to take tons of time. There are times where you can make a snap judgment about, oh, this person's in a very different place just based on the things that they're telling me or the spiritual language that they're using. Very different than I was expecting as a starting place. But you have to begin with understanding that. So, all right, now we're actually, I guess, 60% through of this framework, at least. So now, and only now, can we talk about goals of care. And goals of care, a lot of times when I get a consult for goals of care, most of the time people, by that, they mean, come make this person DNR because I don't think that we should be coding them. And that's a valid, very valid reason, but that's more of a symptom than a diagnosis. And so actual goals of care are questions that a patient or family can answer that are in light of your diagnosis and therefore prognosis, and within the context of your understanding, values, and beliefs, what things are important to you, what matter to you. And these are examples. These are in practical patient language. These are not medical orders by any means. But in light of my illness, look, I want to be able to go home. I don't want to be in the hospital. I want to see my family. I want to live as long as possible at all expense. It doesn't matter. I just want to be alive. I don't care where I am. I want to ride horses. I want to be alive for some event, a graduation, a birth. I want to be able to run a 10K. I just want to be comfortable, or even things like, why am I still here? So again, these things have to be relatively reasonable in light of illness. And so what about when they aren't? So what if a person is wheelchair bound and their goal is they want to run a 10K? Well, and that's an exaggeration, but that's, I think, the easiest way to illustrate this. So the response is, man, I wish that could happen too, but do you think that's reasonable or likely in light of everything that you're hearing me say? And the answer is no. And if it's not, well, you have a bigger problem with somebody who's just defying logic. But offering, kind of in a way, condolences that can't be true. I want to be alive for my kid to graduate from college, and you're dying right now and your kid's 4. Well, that's not going to happen. So I wish that could be true too, but unfortunately, from everything we can see medically, it's just not going to be possible. What other things are important to you in light of where we are right now? So understanding from a patient standpoint what matters in light of your diagnosis, prognosis, and goal understanding and values. So once we can get to that point, then and only then can we get to interventions. And there's a really important piece that I'm leaving out here between goals of care and interventions, and that's us. So this is really the first place that we're doing a lot besides, oh shit, am I on mute? Oh, okay, good.
We can hear you.
I didn't think you'd let me do that for 35 minutes, but had a moment of panic. All right. Anyway, so this is our opportunity for intervention. Diagnosis, yes, we're involved there, but that doesn't really involve the patient. Prognosis, kind of same thing. Understanding values and beliefs, those exist. We just have to find out about them. And goals of care, maybe we can help elicit by giving examples of these kinds of things like what I'm talking about. But really, we don't matter that much up until we're making a recommendation for what do we do. And that transition is where we come in, because interventions are things like, okay, you have widespread metastatic lung cancer and you know you don't want to get chemotherapy, or what we feel almost certainly is lung cancer, you don't want to get chemotherapy. Is there really a lot of benefit in doing biopsy? And you could play both sides, because you can think, well, gosh, if it's really amenable to some type of low burden oral chemotherapy that I could take at home, then maybe if it could extend my life by weeks or months, versus no, I don't want to go through a biopsy if chemotherapy is only going to make me feel worse. And already my functional status has declined significantly over the past weeks or months. But these are the types of interventions that we think about: biopsies, surgeries, going on a ventilator, getting a trach after being on a ventilator, CPR, fluids, antibiotics, dialysis, PEG tube. So even things that are as simple as fluids and antibiotics. And here's the example I use here. I don't know why I keep using pediatric examples, but that's before you pick up 10,000 comorbidities. So it's easier to have a more clear example. But the most simple version of this communication framework that anybody in a pediatrician's office does every single day is an ear infection, right? So your kid's whiny and complaining, and you take them to the doctor and they're pulling at their ear, like it's pretty clear. You look, or it looks like there's an effusion. And so, okay, there's otitis media. That's our diagnosis. What is our prognosis? Well, it's pretty good. Like, we can treat these things. You're likely not going to die. What is your understanding, values, and beliefs? Well, I just want my kid to not hurt and stop being a little bitch or brat. It's really, just I need this to stop. And also, I care about my kid not hurting. So my goal is recover from this illness. So what do you suggest, doc? Well, I suggest we treat with antibiotics. There's your intervention, and then all things are better. So do we actually think through each step of this process? No, but really we're doing it. It just all is one step that happens in our mind without thinking about it. So when things get much, much, much more complex, you have to break it out and really think, well, gosh, you have 3 things that could potentially kill you. So these are these 3 diagnoses. Your prognosis with each one individually is pretty bad, but with all of them, it's really bad. So how do we assimilate that into, is it most important that your goal of care with your end-stage COPD here, in light of my illness, is I don't want to feel like I'm suffocating. I'm terrified of feeling like I'm what do people say? They say, smothering. I'm smothering with an N apostrophe. Aaron was going to tell me, I see it. So they're terrified of smothering. Okay, well, that's a different goal than I want to live as long as possible, right? So our job is to be relatively paternalistic in saying, look, with what I understand about your disease and what I expect, and therefore what's important to you in light of your understanding, values, and beliefs, here's what I would suggest. This is what we should do. Look, a ventilator is not going to help to get you to home, or it's not going to help you get better. So I think it's a terrible idea. And I will tell people all the time that, that certain things are a bad idea. There's lots that we can do, like antibiotics and fluids and things that are relatively low burden. But there are some times where I know things would be a horrible idea. And so I don't want to do those things. And really, I think about that in the context of a bridge. This is a bridge in Charleston, the Ravenel Bridge, which I think back before everybody knew it was so corrupt. But that's where I did medical school, in Charleston. Beautiful bridge. And that has no relevance to the fact that all these therapies that we think about should be a bridge to something, and that something generally is getting better to some degree. So do I want to start something that I expect to be a destination therapy? Probably not. There are some exceptions, like an LVAD that's meant as a destination rather than to go to heart transplant. But will doing this thing get me, or potentially, possibly, likely get me to a place where, get you to a place where we're going to be able to achieve goals or a baseline that's acceptable to you? So artificial nutrition and hydration is that way, ventilation is that way, even antibiotics are that way. In an elderly, demented, severely demented person who's had multiple hospitalizations with sepsis from UTI, treating that UTI doesn't necessarily help somebody recover to a baseline that they want to be if their baseline is right where they were before in a nursing home and not aware or able to interact or communicate with people in a meaningful way. We can choose or offer not to do antibiotics and allow that person to reach the end of their life in a way that's natural and comfortable purposefully. And that's a really weird way of thinking about it. But here's the thing, we're really worried about being too paternalistic and telling people what to do, but we do that every single day. It's just that we're talking about doing things rather than not doing things. And paternalism feels really okay when it has to do with, okay, well, your kidneys are broken, we're going to put you on dialysis. And it feels not okay to say, well, your kidneys are broken, we have a thing that maybe could help that. But we're going to consider if that definitely makes sense for you, because it's way easier to say, this is a thing that exists, this is what we're going to do. But do we offer ECMO to everybody? No, we don't. So we are actually more paternalistic than we realize. It just doesn't feel like it because we're talking about doing things and telling people, well, you have cancer, this is the chemotherapy, rather than helping them to make a decision that's consistent with their goals and values. Okay, so here's where it gets really sticky. Is how do we rectify these things? So I'm giving all of this talk in kind of perfect theoretical terms that this all works out beautifully and this conversation evolves exactly as I plan, but it never happens that way. So what happens when patients or families want to make decisions that are at odds with my own values? And we have to ask, why does that make me so uncomfortable? And the reason is, lots of times is, man, this person says they want to be full code and I do not want to do this because I know it's a bad idea. And I will talk about that sometimes because, people over and over, they're like, everybody keeps coming in here and saying, we don't want to put you on a ventilator. We you shouldn't go on do you want to go on a ventilator? Do you want to go on a ventilator? And what we should be really getting at is, we don't want you to, because we know that's a bad idea for you. Let's focus on the things that we can do to be helpful. But that's why everybody is so anxious and uncomfortable and nervous, is because you're making decisions that I am worried are going to actively cause you harm. And so that's why there's this tension created of, I feel uncomfortable even going in there and talking to these people because they're doing things that I don't want them to do. And you have to recognize where that is coming from. Or the reverse might be true. You might say, this person could live. We want them to go on a ventilator. I'm having a family meeting tomorrow with a patient with a bunch of burns who doesn't want this therapy. They're like, we can get you better, but he doesn't want to. And so you have to give some degree of autonomy there, as long as the patient can understand their medical condition, you can understand their goals in light of that medical condition, and you can make recommendations for how to do that and how to reevaluate when things change. Because here's the problem with this framework, is that this presumes a one-time conversation of diagnosis, prognosis, understanding values and beliefs, goals of care, and interventions. However, medicine is not like that. It's not stagnant, right? It changes every day, sometimes every hour, sometimes every week. So how, once we've gone through this entire framework and we're at interventions, this is what we say we should do, how do we go backwards the other way and do something different? And that's where, this idea comes in, called remap, and you can easily Google it and remember these things. But essentially, it's a way to get from the end to then go back to the beginning and start over, but in a way that's not that flows and is smooth. And so, for example, gosh, we talked 3 days ago about your mom having difficulty with breathing, and we worried that she would get worse. Y'all agreed that it'd be okay to go up to BiPAP and try that and see if it helps her to get better, and then we'll go from there. So I'm recommending BiPAP as a trial for a short time. And now here we are 3 days later, this person's had a MET because they're getting worse and maybe needing intubation and ICU. And so the conversation then is, gosh, you remember our conversation from the other day? I'm afraid we're at a really different place than what we hoped for. And that immediately, that one phrase, we're at a different place than we were when we talked before, whether that's better or worse. I've done this in situations where we're like, this person's dying, and then now they aren't. I don't want to ignore that either, to say, man, we're in a better place than what we expected. Let's go back to prognosis. Maybe it's not a few days, maybe it's a few weeks. So in light of that, I still know all that's important to you, but how do your goals change if my recommended, or if the clinical situation changes? And we use remap, and so we reframe. I'm afraid we're at a very different place. You expect people to be emotional, whether happy or sad about that. You map out a new plan that's based on a person's values and beliefs and goals of care. You align with that plan, like this is the thing that makes sense, and then you carry out that plan. So that's how you go backwards in time. Okay, so I'm hopeful that this one slide, I'm going to pause just for a second there to like let all of that knowledge sink in. And I see my mood is texting me like, come on, bro, I'm literally giving a talk right now. Anyway, that is the framework that if you have in mind, you will be able to better understand how to actually make recommendations and take care of families. And there are always, I've taken care of lots of y'all's patients that it's way, way, way more complicated than that, where different people want different things, or there's ethical considerations, or some of us don't feel even comfortable putting tube feeds in a 140-year-old woman indefinitely, but you have to start with common ground somewhere. And a lot of times the step that's missing is what's important to this person, because we say this is diagnosis, this is prognosis, this is what we do, and we skip over these two steps that are really, really important, and they don't have to take lots of time. You know, a lot of people say that well, I could do what you do if I just had more time. And believe it or not, I don't have that much extra time, but what I do have is this framework and all of the secrets that I'm about to tell you that it would take you a year of palliative fellowship to learn, but it's only 5 words. So I think you're going to do great after this. And we have 13 minutes to do these 5 words. So I think we're set. Okay, so worry. It's one of my favorite words ever in communication, period. And here's why. It does multiple things with a single word. And you can't argue with me. So if I say, if I'm in an ICU and somebody's dying in spite of CRT and ventilation and multiple pressors, they are worsening very significantly by the hour, and I say, your mom's dying, then many families will like to say, no, she's not, like a 4-year-old or whoever, whatever age does that. And so if I say, gosh, I'm really worried that your mom is dying in spite of everything that we're doing, then you can't tell me that I don't worry about that, because you don't know my worries. It's a way to talk about bad things without just saying it overtly, but you are saying it overtly. I'm worried that your mom is dying. So that's number one. Number two, it helps to align you and a patient or family that you're working towards the same thing. So a lot of times, especially when I'm seeing a patient who's sick and going into or having come out of the ICU, and people are at odds because the ICU is like, we're doing a bunch of stuff to this patient I don't really want to be doing, but the family's saying, keep doing all the things. It feels like it's us versus them. And this automatically aligns you to say, look, he's worried about my mom. Or some people will say concern. The third reason is the reason I use the word worry. And as somebody who struggles with crippling anxiety, worrying is natural, right? So I worry all the time. So worrying about somebody else's clear problem is no issue for me at all. So I think that that single word, if you can use a way to work it in, like, I'm worried that these things that we don't know what they are represent cancer, rather than, well, there's some things on your CAT scan, we'd have to biopsy to really know. We don't know what this is. No, we know what that is. And worry is the way to talk about that. So miracles, that's point two here, that this feels like a roadblock to so many people. And I love it when people talk about miracles because it's my automatic opening to continue a conversation. Whereas for many people, you give this beautiful description of everything that's going on medically, and then they say, okay, that's all good and well, but we're waiting for a miracle. And you're like, how do I come back from that? Like, but part of this relies on having some understanding of somebody's values and beliefs, and in this case, spiritual beliefs, but not really. You do want to understand what they mean by miracle, but you take that and allow it to coexist with our actual expectation. And so that looks like, I hear you, Doc, but we're waiting on a miracle. We're just going to keep doing this, and God's going to do a miracle. And I say, well, I hope for that too, but do you recognize that that's very different than what we expect? And most of the time people can say yes to that, because you have to allow these things to coexist, to say, look, this is your hope and I share your hope, but it is not what I expect. And so I'll even take on both of those things to say, I too hope for that, but I am not counting on it. I do not anticipate that that's going to happen. And we have to make decisions that are based on kind of what's right here in front of us, not some hope of something that we have no control over. And likewise, if God or some other being is going to make a miracle happen, that has nothing to do with us, but we've reached the limits of what man and medicine can do. So where do we go from here? And, that can take some turns there where it gets complicated of like, well, okay, I wish for that, or I hope for that too, but my expectation is different. And then they're right back to, well, I'm just going to keep hoping for that miracle. And so you maybe have to acquiesce a little bit and say, well, let's talk about a time-limited trial, which got them out of order here. But that case is, we don't think that we can do anything else that's helpful here. So how about we consider doing a time-limited trial to say most people who are going to expect to recover from whatever it is that we're doing or thinking about doing, whether that's something acute like dialysis or ventilation, or something less acute like nutrition or artificial nutrition hydration. We would expect somebody to be showing some signs of improvement over a week. So can we say for 5 or 6 days, we see how this goes, knowing that this person doesn't want to be confined to this kind of life forever, but we want to have as much certainty as we can about having exhausted any of the reasonable options that could help them to get better. Then a time-limited trial may be a good in-between of like, no, I'm not fully comfort care, but I'm also recognizing that doing these things forever is not really helpful. And artificial nutrition hydration is a big part of that. But this is one of the things that people struggle the most in communicating about. We know, we have evidence that in particular populations, artificial nutrition especially is not indicated and is a bad thing, in fact, but that doesn't translate to having a conversation with a family about that. Like, you point them to the 2008 New England Journal of Medicine article and they are not as impressed as they should be. Like, how do I do all this stuff in my life and read journals? Like, you should give me praise for this, but they never do. So it doesn't work. So you have to recognize that specifically when it comes to artificial nutrition, that it is much less medical and much less practical than it is emotional. So how do we figure that out? And it's tough because we have to find ways to talk about it that can be reasonable to people, but recognizing that emotion is not reasonable. So what do we do when people have something good happen? We bring them food. When they have something bad happen, we bring them food. What do we do when we get together as a family? We have food. A visit to my mom and dad doesn't count unless I have like a certain number of meals there. It's all about the meals. And our whole society focuses on that, but specifically and especially here in the South. So we have to take this away from being an emotional issue and normalize it as a medical issue. That when somebody is not eating because they're not hungry or they're having advancement in their illness, the worry is that they're going to starve, right? And that's what you're trying to get at. What are you worried about? Here's that word worry again. It's that they're going to starve. Well, you know what? To be starving, you first have to be hungry. And if you're not eating because you're not hungry, then you're not starving if you're not eating. And in fact, if we put artificial nutrition in somebody who doesn't feel like eating, then they can't control what they're taking in. And it can lead to more problems with feeling full or vomiting or not tolerating tube feeds. And can it extend life? Yes. But unless that is somebody's only or primary goal, then it is not a thing that makes sense in many cases. Now, if you have head and neck cancer and you say, I'm hungry, but I can't eat, that's a great indication for placement of a feeding tube. Or if you have an illness that we expect you to get better from, traumatic brain injury that's going to take months of recovery, but you can't swallow well, stroke that you're going to rehab from, like these are all great reasons to get feeding tubes. Hello. I'm sorry if I said something offensive, but these are all great reasons to get feeding tubes, but it is not always, hey, this person stopped eating. We need to put a feeding tube. Many times, my interpretation of that is it's really hard to see a reflection on the outside of, or a reflection on the outside of what's going on the inside as this person's body slows down in the last stage of their life. And we don't want to do things that are harmful or invasive and do not help them to get back to a place that they'd want to be. So artificial nutrition and hydration, really hard to communicate about. And even that's the thing that I have the most trouble with, because it's at some point hard to argue with, like, gosh, you're just going to let them die as they're not eating. And yeah, that's kind of the way it's meant to be. It's just really hard for us to see, but it's many times a treatment of family more so than it is anything else. So lastly, just do it. Like, I promise you probably can't fuck it up so bad that I can't fix it. And what I mean by that is that you have to fail and figure out what works and what doesn't. And that I can promise I'm not going to make things worse. I may not be able to make things better, but that's part of where I want you to know that you need expertise when you ask for us. And so do it. What this refers to actually a very personal example here. And it is that, and this is what I'm pretty much ending with, but it is that for my wife and I's anniversary one year, we did this beautiful trip to Charleston and had brunch, and it was just, everything was perfect. The weather and everything. We sat down to brunch and we got some drinks, and then we're waiting for our food. And so I said, naturally, what's the minimum quality of life that you'd be okay with? And for me, that's the most loving expression of that I could possibly give, that I care about you and doing what's important to you. And whereas my wife, for some reason, took that as a death threat. And she was like, why are you talking about this right now? This is not, like, this is the very last thing that I want to talk about. And so, you have to realize that perspective matters. And yes, I, even in my own life, want to do those things that are important in talking about advanced care planning, but at the right time, in the right setting, with the right people, which apparently is not at a 10th anniversary trip. So just so you know, heads up. But we are 3 minutes shy. This is the last thing that I have to look at, is just think about your words. And the one thing here I would draw focus to is this idea of withdrawing care. I never say that. And so many people in the hospital say it. There's nothing wrong with it per se, but there's better ways of saying, well, we could withdraw life-sustaining treatments, or we could shift to comfort-focused care. But withdrawing care implies that much of what I do, especially in the PCCU, is no care at all. And that's the furthest thing from the truth. It might not be as medically intense as much of the other care that we do. But so we like to think about that differently. Or your kidneys are broken, you need dialysis. Well, dialysis could be indicated, but do you specifically need it? I'm not so sure. We've done all we can do. Same idea, that we've reached the limit of what we can do with medicine. However, that doesn't mean we can't continue to do lots of things to take good care of you. So it's and there are lots of these kind of examples that I could give, but thinking about, you make implications with your words that many times we don't realize. And it's really important to think about how somebody could interpret those things, especially somebody who's in a state of great emotional turmoil or even adversity at times when they're not liking what doctors are saying or doing or how their family is doing. So, all right, that's all I've got. I fit it exactly into an hour, but there's so much more that that we could talk about. But remember, like the crux of this I say conversation, of me talking at you is really simple. It's try and get to know people, and specifically what are their values and beliefs, and how does that fit into a conversation about serious illness, and some of those specifics about how do we specifically talk about those things that are important in figuring out. So I will end there. I'm happy to field emails or phone calls or stop at me in the hall or text or whatever else. But I guess if anybody has a burning question or a statement of anything, you're welcome to say that.
Unfortunately, I think we have to go. We all have our team hall after this, but this was very informative and entertaining despite your lack of use of TikTok. We'll forgive you for that.
Sorry. You can follow me on TikTok. I do all the dances and stuff. But,